just introduce myself. So my name's Dr. Jo Mountford. So as you heard, I'm one of the liaison physicians at VCS. My background is I'm also a GP. So traditionally I was working up in Albury-Wodonga and ran the Albury-Wodonga Sexual Health Clinic. But now I'm working full-time with VCS, and I have to say it's been a fantastic change. Everyone says I can't stop smiling since I've got a general practice. So. The other thing, just from my background, is I'm actually one of the working party members. So for the new guidelines and renewal that, as you heard, are coming out, I'm one of the GP representatives on that committee, and we've been madly getting these guidelines together. And I'll be able to go through some of those guideline recommendations, and obviously if you have any questions, I'd love to be able to answer those, keeping in mind that I can only talk about what's been in the public domain. So keeping that in mind, any information I do give you about the guidelines and where it's heading, just keep in mind it hasn't been published yet. So any information I give you, just keep in mind next year, always check that rather than just relying on something I've said today. Okay. Now I'm actually hoping to make this a little bit interactive. So what I'm going to do is, after those fantastic presentations we had, is really just put it into a clinical context, okay? Because that's what's going to happen when you walk out of here today. You're going to go back and the patient's going to say to you, what about this test? And you think, yeah, I remember I heard it, but it's always good to have that clinical background, okay? So hopefully you all feel confident enough that you can ask questions and hopefully provide some answers as well. Alright, so as part of the guideline committee, I have to put this slide in. So this is just talking about where the guidelines are up to at the moment. So as you can see, we have finalised the guidelines. So they have been finalised as of last week, and they're going to be due for release or publication in a few more months. Okay. Alright. So change is inevitable. Okay, you've heard from Stella that 1st of May 2017 sees a major change in cervical screening across Australia. So what do we know? So now I'm going to test you on what Stella has said. Okay, so can anyone remember any of what the major changes are? No slide, perfect. Yeah? Every 5 years, perfect. Yes, start screening from age 25, fantastic. Yep. Okay. Excellent. Okay. So we have got, just to go over them again, 5-year interval screening. As you said, we're now doing a HPV DNA test. Okay. We're using liquid-based media, which no longer using the liquid-based slides. And it's quite funny. I went to a clinic once, and they said, "Look, once this all comes in, would you guys be able to leave all your fixative, because we found it cleans the graffiti off our walls really well." Okay. So, if you've got any spares, let me know. We're now going to be doing exit tests between the ages 70 and 74. And there's also going to be the option for HPV self-sampling for under-screened and never-screened women. Okay, and that will be something I'll go through a little bit more in terms of that. So does anyone have any questions to start off with about the new changes? Sorry? Exactly the same. So it's Australia-wide, 1st of May 2017. Okay. Look, in terms of funding side of things, that is sort of out of our role of recommendation. And I would leave, particularly with different pathology companies. I mean, as you heard, VCS Pathology is a government funded. In terms of the private, look, at the moment we've got no further information around regarding that. So, yeah. As Stella mentioned, Victoria's already had the Compass trial going. Okay, so we've actually got close to 50,000 women that we've recruited onto the Compass trial within Victoria. So, you know, in terms of how this is going and going ahead, I'll be able to give you some information about my experience of recruiting women onto the new 5-year test. Alright, so what I'm going to do to illustrate some of these points is introduce you to 3 women, okay? But as we go through each of these cases, just keep in mind women you see yourselves, okay? Hopefully in each of these women, you'll see your own patients, okay? Probably more than just one. Okay, so we've got Claire to start off with, who is our anxious patient, okay? We can all probably think of one person in our clinic that you think is going to be hard with this 5-year test. We've got Alina, who is our under-screened woman. And then finally we've got Sarah, who is our young girl who's presenting for follow-up, who had already been screened on the current guidelines. Okay. so Claire, our anxious patient. So Claire's a long-term patient of yours. You know she's very diligent. She comes in every 2 years and she's very anxious around having her pap test. She's 38 and has not had the HPV vaccination, and she's due for her regular pap test. Okay, we've already got a patient in our mind. You can see your own patient. Okay. All of her previous tests have been negative, but you know that her mum died of cervical cancer when Claire was just a teenager. Okay, so you know she's going to be highly anxious. And she asks you about this new test because she's heard this 5-year test that's coming out, and Claire's really anxious about it. Okay. So she states this is quite alarming for her. Okay, and she says to you, what do you think about this new 5-year test? There she is. Okay, this is alarming for me. Okay, so these are some of the questions we're going to go through. So how will you explain this new 5-year test to Claire? How will you take the sample under the new guidelines? And what tests will you actually request on your pathology request form? And lastly, we'll talk about some reflex testing that Stella alluded to within her talk. Okay, so is anyone comfortable saying how they might explain to Claire the new 5-year test and what it means? What are some of the important things that you might think about? Yep. It's a more sensitive test. Yep. Perfect. Because you're looking for that causative agent rather than waiting for that cellular change. Exactly. Anyone else? Yep. Waiting for that cellular damage to happen? Yep. Yep. Anyone else? How would you reassure her? Yep. Yep, for her that it's no difference. Yeah. Under a self-collection, and I'll come to that actually. Yep. Yep. So they're really important things, and I think, the main thing that Claire's going to be anxious about is her family history. Okay, because that's the one thing when you talk to a patient, the thing that they remember. And it's really important to explain to her that connection of cervical cancer, these abnormalities that we see on pap smears, in relation to HPV. Okay, so we need to reassure her that we now know it's HPV related. Okay, that there's no evidence that there is a genetic basis behind this. Okay, it's related to the HPV infection. It's also important to say to her that, look, we're actually doing a different test, because when I've been talking to women about this new test, because you're putting a speculum in and you're taking a sample, a lot of women think we are doing exactly the same thing. They think we're still sending that sample off for cytology, but instead of doing it every 2 years, we're going to do it every 5. So it's really important to be clear to the woman because the test is the same for her, okay, and just reassure her that it's actually a different test. And the other thing we want to explain is just how common HPV is. As Stella suggested, it's skin-to-skin contact, and we know that we call HPV the common cold of the cervix. And as we say to women, we don't expect you to go through life without getting a common cold. We actually don't expect you to go through your sexual life without getting HPV. But just because you're exposed to it does not mean it's going to progress. That most women who come in contact with HPV will clear that infection with no problems whatsoever. Okay? It's HPV related. Yep. And it is often this, I won't go through it again because I think Stella did a fantastic job going through that, but this is what I've really found really helpful with patients, to be able to explain this to them. And it's interesting, it doesn't take that much time to go through it all. Okay, if I used to keep one of these in my drawer beside me, and I would always get it out because people like to see that visual difference. And I found it was actually quite reassuring to be able to explain HPV and how common it is and relate it to why this 5-year test is now so much safer. Okay. Interestingly, you asked that. I've actually had more GPs ask me about why we're not doing both. Okay, on a standard screening routine. But no, in terms of the difference, and I would explain that to the women, that in terms of that very minimal difference when you're talking about population-based screening is just so marginal. But that does bring into one of the guidelines around screening of symptomatic women, which I can come to at the end if you like. Okay, so how will you take this test under the new guidelines? What will you do for Claire? Okay, so you take your sample, and then instead of the glass slide, you pop it into your thin prep container. Okay, does everyone know how to do the thin prep samples? Make sure you take the same sample as you would for doing cytology, but you pop it in and you give it a really good rinse around. Okay, we don't want to see just that little light dab and then throw it out. Okay, you've got to really mix up, get those cells off. Okay, now what will we put on the pathology slip? Okay, when you think about pap tests, we have all sorts of requests coming in. We have pap tests, we have cytology test, we have cervical screen, all sorts of things will come in. Thin prep when we'll do cytology. But we need to start thinking about a more realistic way of how we're going to request this. And I think it's really good because most of us have auto-populated forms that just print out cervical cytology. Okay, so we need to be thinking, 1st of May 2017, this is all going to change. Okay, so what do you think might be a more accurate way of requesting one of these tests? Okay, HPV DNA. Okay, yep. Okay. One of the things that I'll talk a little bit further on about that is around what we do when we do what's called reflex testing. So we need to be aware with women who are HPV positive, we will be looking at cytology. Okay, so we need to be a bit more generic about what we will request. Okay, because if we just put HPV DNA, we've got to allow for that reflex cytology to be done as well. So a really good one is cervical screening. Okay, nice and easy. Okay, now you'll notice I didn't put patient's details on there, the name, please fill those out. Okay, but just to give you an idea, and of course we always love you to fill in the Aboriginal and Torres Strait Islander section and everything else on there. Okay, it takes a couple of seconds, but it provides us with so much vital information. Alright, so this is where we get onto the reflex testing. And I know Stella talked about it towards the end of her presentation. So, reflex testing is exactly that. So what we do is when we receive one of the thin prep samples, once we have a HPV positive result, so whether that be 16, 18, or one of the other high-risk HPV, we automatically will do cytology on that sample to allow us to work out what our next step is going to be. Okay. Keep in mind, I'll round the figures up a little bit, but women who are positive for HPV 16, around about 20% of those women will progress to a high-grade abnormality within 10 years. Okay. HPV 18, on the other hand, around about 15 will progress to a high-grade abnormality in 10 years. Our HPV positive non-16, 18, around about 4% will progress. So you can really see why we separate strains 16 and 18 out. Okay. So what we're going to do then is to work out what our next step of recommendation is going to be by looking at the woman's cytology status. So here's an example of what will be happening. So if we've got HPV 16, 18, we're going to send that woman for colposcopy. Okay. Any woman HPV 16, 18 positive on the new guidelines will go straight for colposcopy. But you'll see in between we do a reflex liquid-based cytology. Okay. Now, in terms of women who are 16, 18 positive, it doesn't matter what her cytology shows. If that's normal or negative or abnormal, that woman will still go for colposcopy. But what that step allows us to do is to provide more information to the gynaecologist who's doing that colposcopy. Okay, is that clear to everyone? That, yep. So all 16, 18s will go straight to colposcopy. Now, our other HPV positives, we will do reflex cytology again on these. Okay. Now, if you've got a woman who is HPV positive, non-16, 18, who either has negative cytology or a low-grade abnormality, we're going to repeat her in 12 months, okay, with another liquid-based sample, okay, another thin prep. So what's the reason? Why will we leave this for 12 months, do you think? Sorry? Yeah, exactly, to allow her to see if she will clear that infection. Okay, exactly right. If she's got a high-grade abnormality, on the other hand, of course, we're going to recommend she goes straight for colposcopy at that point. All right, so has anyone got any questions? That's a fairly straightforward. Anxious Claire, you're going to come across Anxious Claire quite a bit with the new guidelines coming in. Okay, so now we've got Alina, who is our underscreened, never screened woman. Okay. So Alina's 49 years old. She emigrated from Belarus about 25 years ago, and when she first arrived, she actually had a pap test at another clinic. Her English at the time wasn't great, and she actually found at that time it was quite painful, and she found it a very negative experience. Despite your best attempts, she's still refusing to have another test done. So, what tests can we offer Elena? Self-collection. Yeah, okay. And what are we going to talk to Elena about with this self-collection? Is it as good as us looking at her cervix and taking a sample? And what about reflex cytology? What are we going to do? Okay. So it's actually, I've only ever had this discussion of doing a self-collected with a under-screened, sorry, I shouldn't say never screened, she was under-screened. And it was actually a really lengthy discussion. Because one of the things that we need to talk about is around what is that barrier to prevent your screening, okay? Because as you know, most women, in my experience, if you take that time and consideration, a lot of women will allow you to do it. Okay, but we always have that small number that no matter what we do and how reassuring we are, will refuse to have the test done. And what we need to be able to communicate to that woman is, look, the HPV test is certainly better than doing nothing at all, which is unfortunately what we've been doing for so long with these women, okay? So the self-screening is really for the woman who's going to walk out that door with refusing to have any further testing done, because we know that the best and safest way is making sure that cervix looks normal and taking the cervical sample, okay? The other thing you need to talk about too is, what is Elena going to do in terms of follow-up? If she does have a HPV positive result, what does that mean for her? Will at that point she be happy to follow up by either, if just say she's HPV 16, 18 positive, 16 or 18, we'll need to send her off for colposcopy. How does Elena feel about that, and will she actually engage in that part of it? And if she's HPV positive, non-16, 18, we're really going to be recommending that she then has a cervical sample taken. And this is some of the stuff Sandy was talking about in her talk. So to be honest, I've heard GPs say, oh, doing the self-collection will be so much quicker and easier than actually doing a pap smear. But in clinical practice, I actually found it a very lengthy discussion. Okay. I've only had one patient that who did it, and she was happy to pay the private cost because it's not current guidelines, and she came back negative, so I didn't have to worry. But, you know, that next step would be quite difficult in terms of where we'd go to from here. Yeah, I'm glad you asked. Okay. All right. So in terms of self-collection, so it is through VCS pathology. It's a Reflex swab, so one of the dry viral swabs. And what the woman does is she'll go off to the toilet and she can take her own self-sample. Now, I haven't got one of the swabs here with me, but I never knew. About halfway down, about 7 centimetres, there's a little line around those swabs. And that's to indicate roughly the length of the vagina. So we just want to make sure that the woman takes a high vaginal swab, that she takes, gives it a bit of a move around. We don't want tonsils, but, just keep it down. But it gives you a bit of an idea of how far, okay? Yeah, group B screen. Yeah, similar type of thing, but it's just using that different swab, okay? And with that, it will then enable her to at least get that result back, okay? Yeah, look, I think in terms of that, it would still need that clinical discussion prior to doing anything. So as part of any of your screening tests, I'd always be asking about any of that first, doing your chlamydia screens if it was appropriate and all of those other things. But, in terms of the self-collected swabs, it does have that high sensitivity associated with it. Okay. Yes, so that's the same swab as our chlamydia swab. So, yeah, it's definitely not a quick option out of doing a pap test that I've heard GPs being a little bit concerned about. Okay. Now we'll have quite a bit of time, some questions at the end as well if there's any of the other guidelines. This is our last case that I thought I'd go through, because I think in clinical practice this is one that probably comes up a lot, is our transition of our current patient onto the new screening guidelines. Okay. So it's May 15th, so we know we've already gone into the new guidelines, and Sarah, who's age 21, comes in to see you, and she says, look, I came in 12 months ago and I had a low-grade abnormality, and I think I need screening again. Okay, at which part we all get very confused and think, hang on a minute, you're 21, we're now no longer screening under the age of 25. What are we going to do for Sarah? Has anyone got any thoughts what we're going to do for Sarah? Are we just going to say, look, we don't need to screen you? Exactly. So we're very reluctant to turn her away, aren't we? Okay, good. Okay, so what test would we do for her? Anything different? No? Okay, good. Exactly. So what we're going to be doing on the new guidelines, it is suggested that for women who are already on the current screening recommendations that you're following up, you will there will be a nice section in there around how you migrate those women across into the new system. Okay, so as an example, so for Sarah, we are going to do exactly the same thing. We're going to do a thin prep sample for Sarah, okay, because then at least that way we're following up on her low-grade abnormality. What would we write on the PAP form? I shouldn't say the PAP form. On the I'm up here saying you don't say PAP. What would you write on the pathology form? Cervical screening? Yep, perfect, excellent. And how would we follow up? So just say Sarah comes back and she's HPV negative. She had a low grade last year and she's HPV negative this time. We don't do cytology because she's HPV negative. What do you think the recommendation for her coming back might be? 5 years, perfect, exactly right. Okay, because she's got a negative HPV, so she's back in 5 years' time. Okay. In comparison, if she's HPV positive, we're going to do a reflex cytology. Okay, and we're going to let that guide us in terms of what her next follow-up will be. Now, in terms of the reflex cytology in this scenario, on a patient who's had a low-grade abnormality 12 months prior, the new guidelines will suggest that it doesn't matter what that abnormality is. If that patient had a low grade 12 months ago and she's still HPV positive, she'll be sent for colposcopy regardless of what her LBC result is. Okay. Yeah, so that one would be, well, purely because she was 12 months ago and you're following up an abnormal. Yep. Okay. So it's going to be, particularly in that scenario, I think, from a clinical perspective, having a patient who had a low-grade abnormality, who might be concerned, she might be your age, she's 22-year-old, 21-year-old, and you're going to do a HPV test and it's going to be negative, and you're going to be able to reassure her now that coming back in 5 years is perfectly safe, and that we know it's a better test than repeating her cytology.